I'm Laura Bontempo from the University of Maryland, and I'm very excited to be here with you today. Thank you for joining us at this course. I know you're on day 2, and some of you day 3, so thank you for taking your time to join us, and I'm really excited to be here. We're going to be talking about asymptomatic hypertension. Don't just do something, stand there. And I love giving this talk because I get to talk to an eager audience of practitioners and tell you to do less. That's usually an easy sell, telling people not to do something. So we're going to talk about that. All right. I got nothing. No disclosures. All right. So we're going to talk about hypertension, what actually it is, which is a little bit more nebulous than you might think, why we care about it. We're going to talk about when to not deal with the hypertension, when to do nothing, and then we will end up with talking about the hypertensive emergencies and your approach to when someone's blood pressure actually does have to be dealt with. All right. So this is a map from 2007 looking at the percentage of individuals over age 20, so pretty low bar there, pretty young age, who are diagnosed with hypertension. And if you can see, if you were in the west half of the country, you were pretty good. The southeast, lots of salt, lots of high blood pressure. Not so good down there, but the west, you were pretty good. It's going to fast forward here. By the way, the lowest category here, the lightest category, sort of the whitish one there, is somewhere around 20 to 23% of individuals diagnosed with high blood pressure. This is 2017, okay? The dark colors have gotten much more, and the low category is gone. The low category on this is no longer 19 to 20%. We start at 24% and go up to 27%. So hypertension is getting more prevalent in this country, and although the West is still better, it's not yet really spared anymore. It's above 1 in 5 individuals above age 20. So hypertension is hitting younger and younger people. We used to think of hypertension as being an old person's disease. Not so much anymore. And although this statistic to me is somewhat disturbing, that it's getting worse, here to me is probably the most disturbing statistic, and that is 11% of kids under age 20 are diagnosed with hypertension. So nearly 1 in 10 kids under age 20 hypertension. So used to be that the kids who had hypertension were kids who had other things going on. They had secondary hypertension. They had kidney disease. They had something else happening, and hypertension just sort of came along with their pediatric disease process. No longer the case. The kids now, the majority of kids who have hypertension actually have primary hypertension. So that the hypertension is then going to lead to hypertension-associated health problems as opposed to the other way around. So if you take care of adults, you take care of kids, doesn't matter what state you practice in, you're going to take care of patients with high blood pressure. I wouldn't even ask, because I know all of you take care of patients probably every day who have high blood pressure. You're definitely going to see it. All right. And why do we care about it? Well, it puts you at risk for all sorts of things, right? Your risk of having a stroke goes up, your risk of having heart disease goes up, and as you can imagine, as the incidence goes up, the associated morbidity and mortality go up. 38% rise in the number of high blood pressure deaths. We're talking deaths primarily related to blood pressure and the secondary effects of high blood pressure. 38% rise in 10 years. That is a phenomenal number right there. So sometimes we have to do something about blood pressure, sometimes we don't. We're going to talk about those two things. We're talking about how much money this all costs. 38% rise, numbers are going up, incidence is going up, kids are affected. The estimate is that the United States alone spends $51 billion with a B, $51 billion on hypertension direct and indirect medical costs. So there's certainly a lot of money being put into this disease process. All right. So now the question is, what is it? Now we've talked about how bad it is and how it's getting worse. Well, what is it? I think you probably all have a sense of what you consider to be high blood pressure, what number is too high for your tolerance, if you're in primary care, emergency medicine, critical care, whatever it may be. And that number's not quite as straightforward as you might think. This is the ACCHA, American College of Cardiology, the American Heart Association definition as of 2017. If you remember back, just 4 years before, hypertension was defined by whether or not you had diabetes, by your age, by whether or not you had CKD, and stage 1 and stage 2 were gone. It was relatively simple. Stage 1 and stage 2 have come back. So what literature you're reading, even in just the past few years, the definition is going to be different. This is what we have now. Okay, so really, if you're above 130 over 80, you fall into the category of high blood pressure. Stage 1, stage 2, that doesn't really particularly matter for the purposes of most of us. How high is too high? Well, here, once you hit 130 over 80, you're in the hypertensive range. Okay, and I say here because if you go across the pond to Europe, The European Cardiology Societies have decided that you have 140/90 is high blood pressure. So in the US, 130/80 is too high. In Europe, 140/90 is too high. So my conclusion from this is if your blood pressure is 135/85, you don't want to be at increased risk for heart disease, just move to Europe. You're fine. You don't have high blood pressure over there. Okay, so just jump across the pond. All right, but we're not here to really talk about if your blood pressure is, if it's 138 too high, it's 141 too high, right? That's not what I do. I work in the emergency department, and I'm happy if my patients have those numbers. Like, that's a really good day in Baltimore, I will tell you that. So we're talking about patients that come in with high blood pressure, not borderline high blood pressure, really high blood pressure, and what you should do about that, all right? All of this can be confusing, right? So don't worry about the borderline numbers. You can decide if you want to go with the European model, the United States model. Pretty much greater than 140/90, everyone agrees that's high blood pressure. All right. So next question is, how do we take your blood pressure? Well, that seems straightforward, right? Every patient you see has a blood pressure on their chart by the time they get to you. The question is, how is that taken? Automatic versus manual. It turns out that interacting with another human raises your blood pressure. There was a study done, 2 studies, as a matter of fact, that looked at the blood pressures on the same patients taken with manual cuffs and taken with automatic cuffs. Each patient, not each patient, the people were not their own controls, but large groups of individuals, and then patients, in addition, were their own controls, where patients were allowed to rest for 5 minutes, and a human came and took their blood pressure. They were allowed to rest for 5 minutes, and then, without anyone entering the room, the cuff simply went off. What do you think was the difference? How big of a difference does this make? A human interaction versus a machine without any warning, just taking your blood pressure? Any guesses? 2 millimeters, 10 millimeters, 50? 50 is too high, right? It's actually somewhere between 15 and 20 millimeters of mercury difference in the same patient between interacting with a human and knowing that you're getting your blood pressure taken and getting the cuff put on versus a machine without anyone entering the room, just doing a routine blood pressure. So first thing, if someone's blood pressure, if you're not sure, people come in, they're nervous, they may be in pain, that initial blood pressure is high, let them rest, wait a little bit, take the blood pressure with a automatic cuff and see what you get and kind of go from there. So machines, they work. All right. So let's say this is your patient. You're at work, and this gentleman comes in. He's 75 years old. He has a history. His chief complaint is that I have high blood pressure. He does not have a history of high blood pressure, but has a history of colon cancer to the point where he's even had a hemicolectomy, disease-free as far as he knows right now. He has a family history which he has already outlived. His mother had a stroke when she was 57. He takes his daily aspirin, as most 75-year-old males will do, or at least be advised to do, and he has no complaints. That's it. You can make this relevant to wherever you work. This can be a patient who went to a health fair in their community, who had a blood pressure screening at their church, who came from the dentist's office where they were going to have some sort of extraction and had a blood pressure taken first. Whatever is relevant to your practice, this patient is coming in to you. You guys all take care of patients like this who someone told them they had a high number? Health fair, something, dentist is a great one, podiatrist, maybe they just had vital signs taken. They end up in your practice, in your emergency department. So the question is, what do you do? Right? What do you do with this gentleman? Those are his vital signs. First thing you do is you check, right? You double check the blood pressure. That's high, 193/108. That's no small blood pressure. The rest of the vital signs look okay, no big deal. He's feeling okay. I'll tell you that your exam is unremarkable. You do a whole good exam, nothing going on. The question is, this guy is your patient. What does the evidence say, and what does your practice tell you to do? What does your institution, wherever you work, tell you to do? Should you do diagnostics? Should you get a basic metabolic panel, check a urine, EKG, look for the heart size and the chest x-ray? Should you scan the gentleman's head? As far as therapeutics, you're going to go with IV or oral antihypertensives. What's the choice there? Right? You guys will have to make these decisions on a pretty regular basis for your patients, I assume. But before we decide on any of that, first we're going to say is, what's his diagnosis? What's this guy's diagnosis? We don't really know he has high blood pressure, although that number is pretty up there, right? To diagnose someone with high blood pressure, you have to have more than 2 high readings on 2 separate doctor's visits, or 2 separate medical visits, I should say. So I'm pretty certain this guy's going to have high blood pressure given those numbers, but I can't really make that diagnosis yet. Elevated blood pressure. So this is what came out in 2013. The Joint Commission called this asymptomatic markedly elevated blood pressure. Right? The patient has no symptoms. It explains what it is. I would have really loved it if they called it markedly elevated asymptomatic hypertension, because then I just could have called it meh. Would have been much easier. But this is what they came up with, okay? Greater than 160 over 100 falls into this category. If you read some of the literature, sometimes it will be defined as 180 over 110. Again, slight differences in definition of these entities. It doesn't matter. If you're greater than 160 over 100, your blood pressure is high. We have to figure out what decisions we're going to make about that, okay? Hypertensive urgency. Who still uses the term hypertensive urgency? No one's willing to admit to it. Somebody out there has to. Yes, okay, a few brave souls put their hand up. And I'm going to say, please, let's get rid of that term, okay? This is from 2013. This was specifically taken out of the Joint Commission. But for those of you who use it, I'll let you know why the term is still hanging around. This is part of the Joint Commission. Unfortunately, the term urgency has led to overly aggressive management of many patients with severe, uncomplicated hypertension and aggressive dosing with intravenous drugs or even oral agents to rapidly lower blood pressure is not without risk. So they didn't just leave it out. They said they took it out and explained why they took out the term hypertensive urgency. So that's great, right? That's years ago. That's many years ago. It takes a long time to get something out of our lexicon, but we were making progress. It was going. And then, in 2017, the ACC, AHA, and as I like to say, and friends, because there's too much alphabet soup to list all those agencies, came out with this, and they put the term hypertensive urgency back into the guidelines. So we worked for a long time to try and get it out. Now it's back. So it says, hypertensive urgency, your blood pressure is high, you have a severe blood pressure, but you're otherwise stable. No evidence of end organ damage, sort of no big deal, but the term urgency is in there. And if you look at the second part, no indication for referral to the emergency department. Yes, I was so happy they put that in there. I have literature. I can put up guidelines. Immediate reduction in blood pressure in the emergency department or hospitalization. So for those of you who still use the term hypertensive urgency or hear the term hypertensive urgency, because at least that term made it back into these guidelines, I don't think it's actually going away, even though for years I've been trying to get people to stop using that term. It's there. Pretty much they put the term back in and said, don't do anything about it. A little bit of a mixed message. It's urgent, but don't do anything. Don't refer, don't even necessarily treat for that. So that's where we're kind of stuck with the term urgency. I don't like the term urgency. You have high blood pressure, you have hypertension, meh, as I like to call it, markedly elevated high blood pressure, or you're having a hypertensive emergency with evidence of end organ damage. All right. So, what are you going to do? This guy's in your emergency department now. He has his high blood pressure. He's feeling okay, but that blood pressure's high. Realistically, first thing you should do is just wait. 20, 30 minutes. Have the automatic cuff recheck it. Okay. That's the easy route. Right? About 20 to 30% of patients will have their blood pressure reduced to non-markedly elevated range. So in other words, not back to normal, but less than 160 over 100, just with this intervention. And if that was the concern that your patient came to the emergency department with, or disposing this patient, some hospitals have guidelines about certain blood pressures you have to have on a patient in order to dispo them. Yes, I see some nods, right? This is pretty common, unfortunately, all around the country. Just wait them out. Leave them be for a little bit. Don't stick them with needles. Don't start IVs. Just let them rest. Put that automatic cuff on and recheck it 20 to 30 minutes. 1/5 to 1/3 of your problems are going to go away right there. Okay. ASEP came out and knew this was a problem, right? These patients are being referred to the emergency department for high blood pressure, and the treatment was all over the place. And we were actually causing harm to some patients. And there was a lot of pressure from the individual provider, but also from the institution, to not discharge people with crazy high blood pressures. And of course, we're all worried about risk-benefit to the patient, and there's a money aspect. So ASEP said, in ED patients with asymptomatic elevated blood pressure, does screening for target end organ reduce rates of adverse outcomes? So remember, the word screening is in there. The patient's not having evidence of end organ damage. Should you be doing things to see if patient has end organ damage? So you get the EKG, right? You want to look for LVH. Does that change anything? It actually doesn't. There's no benefit. This was looked at for patients who came in and had these things done, because unfortunately there was a very big database of patients who had these things done with markedly elevated asymptomatic high blood pressure. No. How about that chest x-ray looking for that big heart? No symptoms, no benefit, doesn't change anything. UA, looking for protein, looking for cells. No benefit, doesn't change long-term outcome. Creatinine, sending some blood work off. All these are relatively non-invasive, EKG, chest x-ray, and UA. Do we need to stick your patient for bloods? The answer to that is, well, yeah, maybe, right? CKD is asymptomatic. Patients don't know they have it. You don't get kidney pain, right? You get chest pain if your heart's ischemic, but you don't get kidney pain if your kidney's ischemic. So if you're going to do anything, and you're obligated to do nothing, but if you're going to do anything, the one thing that might actually change the outcome or change the disposition for this patient is getting that creatinine. See if their high blood pressure is affecting their kidneys, okay? Suggested benefit, that's how it's phrased. So if you want to do something, check that creatinine. This is the only thing that changed disposition. Something like they found 4 of all the patients, 4% of them, so low number, but 4% had abnormal lab values, and almost exclusively was the creatinine. They found a few diabetics along the way, so a few unanticipated elevated glucose readings, but most of the time it was the creatinine because of that asymptomatic CKD. Okay? So don't scan their head. Don't get the EKG, UA, chest x-ray. See, your job's getting easier, your shift just got a little bit better. You can leave these things alone. Okay. ACEP looked at a second question, also based on asymptomatic markedly elevated hypertension. Does ED medical intervention reduce the rates of adverse outcome? Okay. Are we helping people by doing something about their blood pressure in the emergency department? Are we harming people by doing something about their blood pressure in the emergency department? The answer is no. We don't need to intervene because it does not change the long-term outcome. But with most yes or no questions, there's a but that comes along with it, right? You don't have to do anything in the emergency department, but you can't discharge your patient and say, good luck, someone should take care of this for you, right? You do need to arrange follow-up for your patient. Should be followed up. Now that's usually where there's some sort of groan or shifting uncomfortableness because people can have a lot of challenges getting follow-up for their patients. And if I say, you don't need to do anything, but your patient should get followed up within 48 hours, that's not going to happen where I work. I will tell you that. I don't know what kind of practice settings you guys are in. Maybe you can do that. But here's the nice part. They didn't leave us hanging. They put this in. And if you look, if you look, you should have follow-up, and follow-up does not have to be immediate. Right, within 1 month of the initial diagnosis. So there's not a pressure to get someone seen in a day or two, but it is appropriate and good medical care to make sure you have arranged follow-up for your patient. Now, optimally, again, always another caveat, optimally the patient should be seen within a week because starting oral meds earlier results in better long-term outcomes. That sort of makes sense. The less time you have uncontrolled high blood pressure, the less risk of cardiovascular disease and kidney disease and all that other stuff. But there's no obligation to keep someone in the hospital because you can't get them an appointment for 3 weeks. That is perfectly acceptable. But do the right thing. Try to arrange for follow-up. I know that I can get patients in to area clinics, primary care doctors, things like that. We have a wonderful organization called Healthcare for the Homeless that takes care of people who are homeless and at risk of being homeless. I can get them into there. So find what your resources are and just make sure you can arrange follow-up for these individuals. All right. Special considerations. If the patient doesn't have primary care follow-up, if you think the patient can't handle getting themselves to primary care follow-up, there's some other reason why you think the patient can't do this as an outpatient, then you can consider getting the EKG and things like that, knowing that you're really doing primary care work in your emergency department, which is not always so horrible if that's the right thing to do for the patient, but you certainly don't have to, okay? Now, if your patient has a history of end organ damage, right, they've already had an MI, they've already have CHF, you know their kidneys are bad, they've had a stroke, and transplant patients. We're a big transplant center. So when patients come in asymptomatic, but they have someone else's kidney in their body, I tend to get a little bit more aggressive about managing that blood pressure. So these are the exceptions when you want to think a little bit harder about either starting something in the emergency department, doing a little bit more of a workup, or making sure that early follow-up is arranged, not that 1 month sort of partially delayed follow-up. Special things to think about. And then there's that oh-so-fruitful lifestyle discussion, right? You're going to tell your patient, stop your smoking, stop eating salts, get up off the couch, put down the remote control, walk around a little bit, all those things that we try to do for patients. Hopefully some of them listen. But that's really the number one intervention. It's hard, right? It's much easier to take a pill than to get up and walk a half a mile every day, right? It's a tough thing. But we are obligated to at least try. right? Maybe one person hears us, and we make a difference in someone's life. They don't have to go on blood pressure meds because they realize they have high blood pressure. We tell them about the risks and stroke and all those things that can go wrong. So at least try. Give it a good try. Tell them to try and adapt somewhat of a healthier lifestyle. Because the other thing that we do know is for every 10 millimeter reduction in the blood pressure, systolic and/or diastolic blood pressure, you reduce your risk of adverse events. So it's not like your blood pressure is high or your blood pressure is normal. As you bring your blood pressure down, your associated risks go down as well. So even if a small intervention can lower their blood pressure a little bit, you've made some big progress for that patient. All right. So how well do we do? Let's be honest. We've all taken care of patients with high blood pressure. They came in for sprained ankle. They came in for something completely unrelated. You see that number. It's 170 over 95. Who puts hypertension in the discharge instructions? Make sure they tell the patient they have hypertension and make sure tell them to get follow-up. Good. A few brave souls raising their hand. That's good. Hopefully more people are. But overall, this was one study done looking at a group of individuals, just looking at charts about who came in with something non-hypertension related. 5% of patients had written discharge instructions saying that they had hypertension and that they should follow up. 5%. But remarkably, at a 4-week follow-up phone call, this part kind of blows my mind. 65% of patients remembered being told they had high blood pressure. So I never thought my patients listened to me at all. But it turns out that 65% of patients realized that they had been told several weeks after their initial visit that they had high blood pressure and they should follow up. But only 5% received it in the written discharge instructions. So if we're making the effort to tell people that you have high blood pressure, just click that box, whatever EMR you use, put that in. Recommend that patients at least go and have their blood pressure rechecked. You might make a long-term difference in this patient's well-being. So bottom line, if you come in and this is your blood pressure, you say, why'd you come in? Why'd you come into the hospital today? What brings you in? Is it blood pressure related, or is this just an incidental finding and you should follow up with your primary care doctor? So remember, this is your guy. He came in, that was his blood pressure. You do your due diligence, you put him in the room, you leave him alone for 30 minutes, the cuff goes off, and it's about the same. Honestly, who's going to discharge this patient with this blood pressure? Yeah, not many folks. I will, because the evidence says that rapidly lowering this has greater risk of harm than good. And a lot of times when I give this talk or a version of this talk, I hear I'm not allowed to. I can't dispose someone from the emergency department with a diastolic that high. Did that happen to any of you guys? Yeah, oh yeah, I hear oh yeah, right? There's evidence from ACEP, from the ACC, AHA, from the European Society, it's all out there that says don't do more. You can do harm by doing more. What I will tell you at the end of your PDF is I very rarely put a list of references as my last slide, but for this one I do, because I find when I'm done with this talk, I get inundated with I need the evidence, I have to show my chairman, I have to show my clinical director, whatever it is, because I can't do this on my own. I'm not allowed to discharge people like this. But I would send this patient home. And pretty much this guy needs a doctor's appointment. That's what he needs. He does not need anything else. You can send that creatinine if you so desire, and that's perfectly fine, but he does not need antihypertensives. He specifically does not need IV antihypertensives. Risk outweighs benefit. Okay. Any questions about that? Yeah, sir. Half the people you see are sent in by their primary care physician for asymptomatic high blood pressure. I usually call the primary care doctor and send them back, which is hard on the patient. And financially and time-wise, the patients aren't particularly happy with that, but I don't want to harm the patient. I'd rather upset the primary care physician, have my press gainies be a little bit lower for the patient, than risk harming the patient. And there is harm with rapid blood pressure lowering. We're going to talk about that in just a moment. Okay? All right. I'll take more questions at the end. Now that is very different from hypertensive urgency. I'll get your questions, sir, just let me get to this part. So hypertensive emergency is a different thing. I just said urgency, didn't I? Oh my gosh, that was totally a slip. Hypertensive emergency. I don't use the term urgency. This is a totally different thing. This is not a number. This is a patient presents with evidence or symptoms of end organ damage. Something is going on, and their blood pressure is high. So very different from the first patient, okay? This is rare. 1% to 2% of the patients you're going to see have hypertensive emergency. It's acutely progressive end organ damage. So if your creatinine is 3.2 when you come in and now it's 3.6, that's not a hypertensive emergency. If your creatinine is 0.9 and someone checked if your blood pressure is really high and now it's 7 or even 3.5, that's something you have to worry about. If you're having an MI, that's something you have to worry about. So it has to be acute. Right? Here are the end organs we worry about. We worry about your heart, your brain, and your kidney. If it's a pregnant female, you also worry about the uterus, of course, eclampsia. But these are the majority of the patients you're going to worry about: heart, brain, and kidney. What do you need to do here? You need to reduce that blood pressure. Here's where you get aggressive: IV medications. Reduce the MAP by 25% in the first hour. 25 to 30%, you have a little bit of a buffer in there. You want to get that down pretty rapidly. Over the subsequent 6 hours, you want to get them out of that markedly elevated hypertension number range, so below the 160 over 110. Then, hopefully they're admitted by then. There's more time. For the subsequent 2 days, you then want to get that down to what's a normal blood pressure, okay? You don't want to have it go crashing from really high down to normal in that first hour, because that is dangerous, and here's why. This is how you normally perfuse your organs. You can see the organ perfusion and mean arterial pressure. When your mean arterial pressure gets too low, your organ perfusion goes down. We call that shock, right? That's what happens. Pretty flat range of normal. When you're hypertensive, that whole curve shifts over. It shifts over. So if you look where you would, if the middle of the flat part of the hypertension curve, if you're there, and all of a sudden I get you down to normal really fast, look where you are on that end organ perfusion. You're going to hypoperfuse your end organs at what we consider a normal blood pressure, because your organs are used to a higher blood pressure. Does that make sense? This is why you need a gradual reduction. If I take someone who has had high blood pressure for a long time and all of a sudden they're in a hypertensive emergency because they have now congestive heart failure on top, or an MI, let's say, on top of their long-standing untreated hypertension, and I want to normalize your numbers, I'm going to make you worse, not better. Let's do some math here. Got to think about this because these numbers can be scary. So say this patient comes in, 238 over 125. I've seen this patient. I bet most of you have taken care of this patient. We want to calculate the MAP. So systolic plus 2 times the diastolic divided by 3. You can break that up. You can do it with fractions. To me, fractions are hard. This is easy. It's multiplication and division. Okay? Systolic plus 2 times the diastolic divided by 3. That, by the way, is an estimate. So if you ever wonder why, if you calculate the MAP and the MAP on your blood pressure machine is slightly different, the one on the machine is more accurate. This is sort of a rough estimation of your MAP, but it's generally what we use. Okay. So the MAP on this person, the MAP is 162.7. So their mean arterial pressure is hypertensive for a straight systolic. It's really, really high. We want to reduce that by 25%. So we're going to take 75% of the value, we'll reduce it by 25%. You are going for a MAP. Your goal is a MAP of 122 millimeters of mercury. Okay? And that's why you have to do the math, because that seems like a crazy high number, right? A MAP of 122. Force yourself, get at your iPhone, do the calculation, plug it into MD Calc, whatever you need to do, but put that down as a parameter. Let your nursing staff know, or whoever is giving the meds or titrating whatever drip you choose to control this, that this is what you're going for, because it seems disturbingly high, your end goal. Okay. That would be like a blood pressure of 180 over 93. That comes out to that MAP. So when your patient's still having their MI and they're crushing chest pain, 180 over 93 is what you're going for. That's when you're going to pat yourself on the back and say, I did that in the first hour, I'm happy with myself. All right. So we talked about the risk, and I said risk-benefit ratio, risk-benefit ratio. Let's talk about what we actually do when we overshoot. Because we overshoot, that happens. You know, blood pressure medicines are not an exact science, and everyone reacts to them differently. This is a 2007 study done of patients in the emergency department with hypertension. 57% of patients were excessively treated. So over half overshot that MAP reduction in the first hour, or the subsequent 160 over 100 lowering in the next 6 hours. Okay, doesn't matter. I overshot. Is it a big deal? Well, yeah, about 4% of patients had an ischemic event. So people come in because they're afraid they're going to have a stroke because their blood pressure is too high. You lower the blood pressure too fast, you give them a stroke on the other way, right? They're worried about a bleed, you end up with an ischemic stroke. So 4% of patients, the risk is not small. You want to titrate your drips, give repeat doses, you really want to follow those guidelines. Now that all being said, those are our guidelines. That is our standard of care, and that is what we do. A Cochrane review was done that said, does this make a difference? Do you decrease the morbidity or mortality from patients with heart attacks if you follow these guidelines and lower their blood pressure? Do you help patients who are in AKI, any of that? And we really don't have data that says that lowering the blood pressure will make someone's morbidity or mortality from their heart attack, their congestive heart failure, any of that better. Okay. That being said, this is our standard of care. This is what we follow. Don't lower it too fast. Undershoot rather than overshoot. That's the better option. This. Look at that quote. The greatest danger of a man with high blood pressure lies in discovery, because then some fool is certain to try and reduce it. But more importantly than the quote, look at the year of the quote. That quote was from 1931. It is 2019, and we're still having the same discussion about not lowering blood pressure too much. It is a risky thing to do. Okay. I'll talk about questions in a moment, because I knew there were more before when we talked about guidelines from hospitals. Bottom line, if someone has markedly elevated blood pressure, it's a number, right? You're not obligated to do anything. You can wait and watch, see what happens, see what their blood pressure does. You can consider starting an oral antihypertensive in the emergency department if you want to. And there's also an additional part of your PDF which has some guidelines about what things can be started. Thiazides are very safe. Start a low-dose thiazide, low-dose ACE inhibitor, very safe things. You can start your patients on that. Please, I beg of you, do not give IV medications to these patients. You will lower the blood pressure too quickly and risk causing harm, okay? And make sure they get doctor's appointments. Hypertensive emergency, that's more than a number. That's based on your patient's symptoms, perhaps on their EKG. If they're having that chest pain, you're not quite sure what to make of it. Oh my goodness, it looks ischemic. I'm now worried about this. You want to follow your numbers, your symptoms for end organ damage, and you do want to reduce. And you want to reduce that MAP. Do the math, don't estimate. It's really hard to estimate because these numbers are off the charts high, hard to figure out what you're shooting for. 25 to 30% reduction within the first hour. IV medications, okay? Now, I know we talked earlier, some people had other questions about pressures from above to not discharge patients. So when I asked who would discharge the patient with a blood pressure of 180 over 109, about 6 or 7 hands went up. So I know there were some comments about that. You had a question earlier, sir.
My question was, you kind of touched on it, but they were non-compliant.
So you're talking about putting patients in observation to reduce their blood pressure by 25%. Now you'd be talking about patients with hypertensive emergency, not asymptomatic patients. So if you... Let me just clarify one thing. The 25% reduction is not for asymptomatic patients. Absolutely not. That's for patients with hypertensive emergency. So if you come in with a hypertensive emergency, it's because you have pink froth coming out of your lungs. You have an MI that has a STEMI, or you have positive markers or an ischemic EKG. Those are not the patients I think about of being put into observation. Those are the patients I'm thinking about putting in step down or an ICU. That clarify? But the patients who are asymptomatic, don't do that 25% reduction. You can hypoperfuse their organs and make them worse. Yes, sir? Yeah, I get it. Is there any number? What's my tolerance? How high is too high for me to send someone home? I think everyone has some sort of number. Knowing one, the data, and also knowing I have multiple guidelines from national organizations to back me up, my number is really high. And nursing looks at you funny when you're like, but their blood pressure is like 200 over 120, and you go, it makes you inside kind of feel a little uncomfortable, but you go, I know the evidence. I will sometimes start the oral medicine there and then arrange for earlier follow-up for that patient. But there really is not an absolute number. And patients ask that too. So how high does it have to go before I have a stroke? There's no answer on that, right? If all of a sudden your blood pressure spikes, you just did a whole bunch of cocaine or something like that, right? If normal blood pressure, you did a ton of cocaine, your blood pressure spikes, you could have a stroke right then. It doesn't matter what the number is, it's long-term damage. Yes, ma'am? So that's an excellent question. And the evidence, so the question was, do you scan every patient who has hypertension and comes in with a headache? That is very controversial. And I would love to give you an evidence-based answer to that, but the evidence that gives the answer depends on what you read, because it totally varies. The question is, do people have headaches because of high blood pressure? Or do people have headaches, are in pain, and we find that they have high blood pressure? And really depending on what you read and what science you choose to believe, you can go either way. You have good backing for yourself in the direction. So no, I do not. I do a good detailed neuro exam. I mean, the whole thing, you know, the finger to nose, and look up and look down, and pat your head, rub your belly, all that kind of stuff. And if it's a non-focal neuro exam, I do not scan that patient's head. Question is, what is my drug of choice for the IV treatment of a hypertensive emergency? I think you heard some of it earlier, labetalol. It's a good go-to drug. The one I will answer that in two ways. One, labetalol, I really like. The one that I do avoid is hydralazine, because the effect, IV hydralazine, the effect on the individual varies tremendously. You can have a small decrement in your blood pressure or a very large decrement in your blood pressure. So if I can use labetalol, I'm generally going to use labetalol. Yes, sir. So the question is for patients who are going to go home. When you asymptomatic hypertension, you choose to start an oral agent in the emergency department. Is extended release better? Absolutely. The fewer times per day your patient has to take their medicine, the more likely they are to be compliant. So I can give you metoprolol and have you take it every 6 hours. The chance of that happening is small. Or I can give you the extended release and have you take it once a day. Much higher chance your patient is going to do that. I often have patients, I tell patients, if there aren't little kids in the house, to keep their medicine by their toothbrush. You wake up every morning, your body sort of reminds you to brush your teeth. There's a water source right there. Put your pills by your toothbrush, unless you're worried about little ones getting into your medicines, obviously. You know, brush your teeth, take your pill, and I try and do once daily medications whenever I can. I do not, just to be, as a caveat, if someone's in the emergency department at like 12 o'clock at night, I'm seeing them, I don't start their once daily medicine at midnight, because you have to be careful about that, right? I'll tell them to go home and take it at whatever time they would normally get up the next day, so they can get it into a routine. Excellent questions, yes? So the question's about patients with very high blood pressure who have soft signs, not definitive end organ damage. If there's a question, I'm going to go ahead and work them up as if they have end organ damage. If someone has transient global amnesia, I'm going to work them up as if they had a TIA, even though I know that's an unusual presentation of a TIA. But absolutely, I'm talking about the patients who you say half the patients you see come from their primary care doctor's office. We have a very active dental practice at University of Maryland. The dental school sees a lot of patients, and they will send patients over routinely. You know, our ENT clinic will send patients over. We get referrals in, and I always feel so bad because these patients come in, and I say, yeah, we got to get you an appointment. And sometimes I'm sending them back to the patient who sent them, to the doctor who sent them to me, but I'm always going to make a phone call and explain to the doctor what's going on, so we don't play this sort of ping pong with the patient being the ping pong ball getting passed back and forth, because that's not fair to the patient. I think I'm just about out of time, but I think I have time for one more question if anyone has anything. Now, so I have one question for you. Who here has guidelines about what blood pressures patients must have for the patients to be admitted to the floor? So your patient came in with appendicitis, they have a really high blood pressure, and they can't go to the floor because their blood pressure is too high. I'm putting my hand up for that one. This is an ongoing battle at my own institution. Nobody? You guys can say, oh, okay, there you go. All right, I figured it had to be someone besides me. There's sort of this urban legend that patients can't go to the floor if their blood pressure is above 180. And show me the literature. Show me any evidence that tells me that that is not safe for this patient to do. And what you end up doing is the temptation, which you really have to fight against, is just give them a little shot of labetalol, take their blood pressure, send them up, right? Fast, easy, dangerous. Don't do that. I will give them an oral blood pressure medicine and tell the floor that I've intervened, that it should come down and it needs to be rechecked. I've done something. I've somewhat placated them by having some intervention, but I will not risk harming the patient to please protocol. That's it. All right, I'll be hanging around. Thank you, guys.